Well, I'm really excited to be talking to you guys today. And my job today is to teach you a little bit about the new oral anticoagulants, which are mostly we mean rivaroxaban and dabigatran. I was a little intimidated by this topic, hopefully like a lot of you guys, in that I feel like I've spent the last year or two basically pretending they don't exist, and that hopefully they're just going to go away. I'm not going to have to deal with them. But I think like a lot of things in medicine, as we learn about things, we certainly become more comfortable with them. I'm a little less intimidated by the fact that we are going to have to care for these patients who are going to be on medications that maybe we don't like the idea of and that we don't really understand. So my goal today over the next 15 to 20 minutes is to teach you guys a little bit what I've learned over the past couple months as I've been prepping for this talk. Hopefully you guys will understand that people are going to be on these and that we need to know about them and that I don't think these are going away. Hopefully going to teach you guys a little bit about these medications and the potential options for treatment when we get patients that are critically injured that present to our ERs and our trauma units. I also promise to do it without any slides that look like this, because I hate biochemistry. So we asked a bunch of emergency medicine and trauma personnel what their first thought was when they heard the word dabigatran. So you can see that as a group, we're not particularly thrilled by these agents. And I understand why. We take care of patients that bleed. We take care of patients that are injured. We take care of patients that bleed a lot on aspirin and Coumadin and Plavix and medications that we can potentially reverse if we need to. So now we've got patients that are going to be on medications that we can't reverse. Bad things are going to happen to them, and they're going to bleed a lot. And we're supposed to take care of them. So I can understand why we feel like this, because this is exactly how I feel. The problem is that we need anticoagulation. AFib and thromboembolic disease are bad diseases, and they're common. There are about 2.7 million Americans that have AFib, and untreated and unanticoagulated, about 5% or 1 out of 20 of those will go on to have a stroke every year. So that's huge. Anticoagulation can decrease that by about 2/3. So people need to be on anticoagulation for those diseases. Thromboembolic diseases are also bad, and they're common, and they can precipitate PEs, which we know about, and obviously need anticoagulation as well. People need to be on anticoagulation for weeks to months to the rest of their lives after having recurrent DVTs or PEs. So again, people need to be on these medications. The problem is that Coumadin is hard to take. There are a lot of complications with it. People have a hard time getting anticoagulated on it. And even with people that are compliant and go to their Coumadin clinic and do the things that we want them to do, at any given time, only about half the people on Coumadin are adequately anticoagulated. So it's a hard medication to take. I could tell you a little bit about what it's like to be on Coumadin, but we have a video of a patient who's actually the father of one of our fabulous ER nurses who agreed to give a little bit of his perspective on what it's like to be on Coumadin.
Kelly, I've been on Coumadin since 2006, since my second episode with deep vein thrombosis. In the summer of 2006, again in the workplace, I was sitting at my desk and I had this odd sensation in my right shoulder, and I could feel movement of something going down my right side. The pain was there. You go home, you sit in a recliner with your arms up over your head, basically for the evening, and then you come to grips with the fact that you better get into the hospital. Again, hospitalization for about a week, put on the heparin, and released from the hospital. But doctors decided at that time that I needed to be on Coumadin basically for the rest of my days. Coumadin has worked very, very well for me. The most important thing is that I have peace of mind knowing that my INRs are all going to be in range. That's very important. The cons are every 5 weeks I have to go in and have my INRs checked. I do have to watch my diet, as that is very necessary. But I've had INRs that range in the low 2s, so like 2.1 to 2.4 consistently, basically all of these years. It gives me great comfort to know that Coumadin is available and does what it does for me.
And I think he's really probably the most compliant patient we're ever going to get. He's the father of an ER nurse. Coumadin has worked really well for him, and he's had good INRs, but a lot of our patients aren't that compliant. He still talks about how you have to watch your diet. He had to be on heparin. He has to get his INRs checked still every 5 weeks. And some people just can't do that. And so I understand why these agents were developed. They work, we think from the initial literature, they work as well as Coumadin does. The bleeding rates are about the same. And they're attractive to patients. You can take them, you have to take them twice daily, but as soon as you start them, you're anticoagulated. You don't have to monitor INR. You don't have to have these frequent checks. There are very few interactions with medications and with diet. And so really for patients, it's a lot easier to take. So I understand why they're coming about, and that for a lot of patients, these are a viable alternative to our traditional anticoagulants. I think the problem is, as emergency medicine and trauma personnel, we really can feel like we're caught in this tug of war, because we have a lot of valid concerns about these medications. We don't know what happens to patients who have traumas and bleed. We have virtually no literature about what's the right course of action to take when we get sick trauma patients through our ERs and in our trauma units. And on the other hand, we have a lot of pressure from outside places telling us we need to use these medications. Patients like them for the reasons that we've talked about. Providers like them a lot because there's less hassle. Patients get anticoagulated quickly. And then obviously, if you have noticed all the marketing that's out there, the pharmaceutical companies really like them. And there's a big push to use these medications. I think the end game is that these aren't going to go away. And in fact, as more indications get used, right now, several of them are approved not only just for the treatment of non-valvular AFib, but for prevention of DVT in the perioperative setting, as well as treatment of PEs and DVTs. We're going to see more and more patients on these medications. And so, fortunately, we can't pretend they don't exist. And we're going to be asked to care for these patients when they come in injured through our ER and through our trauma units. So I want to teach you a little bit about these agents. Primarily, when we're talking about the new oral anticoagulants, we're speaking primarily of dabigatran and then the Zabans, which are rivaroxaban and apixaban. Again, the pros to these are some things we mentioned a little bit, that they're fairly well tolerated. They reach adequate anticoagulation within an hour or two, and that there's not a lot of the hassle that people who take Coumadin are used to. I know I promised no coagulation cascade, so I made a better one. And this is my version of the coagulation cascade. So you start with platelet and coagulation factor activation. Then there's a lot of very exciting biochemistry magic, and then we end up with a clot. And really, I think this is basically what you need to know about anticoagulation, or about the coagulation cascade. And depending on which factor is involved in this lots of exciting biochemistry magic part, that determines what's going to happen with regards to that agent. So warfarin and the heparins act on different factors than these new oral anticoagulants do. And the factor that you act on is going to determine eventually what potential treatments might reverse that agent, but also what lab values are going to be effective. So it's not really a surprise that these new agents are totally different than warfarin, because they act on completely different parts of this cascade, and they're just very different agents. I broke this down a little bit if you want a little bit more detail, though, again, I'm not a biochemistry fan. And the two factors that we care the most about are factor 10 and thrombin. And the reason is that the Zabans act on factor 10, so rivaroxaban and apixaban. And if you look at the name, this is really helpful. It's very tricky. They're the 10A bands or the Zabans, so they work on factor 10. And then dabigatran works on thrombin. This is important for a couple of reasons, that if you look in the literature, a lot of times they'll be referred to by these names. So the 10A inhibitors or the thrombin inhibitors. But also, we can measure thrombin time. And so that's helpful because if you can remember that dabigatran acts on thrombin, you can check that lab. And if you have a patient who's on an undifferentiated anticoagulant that comes in, you can look at the thrombin time. And that can help you a little bit determine which agent they might be on. So I picked 3 things about each of the agents that if you can remember anything, that hopefully you'll at least remember these. If not, you can look them up and remember that we talked about them. So first of all, with dabigatran, it has a really short half-life. And this is important to us for a couple of reasons. First, that if you're putting people on these medications, they have to take them, so they're dosed twice daily, and they have to take them twice a day. If you miss even one dose, you can start to become hypercoagulable. And so for us taking care of trauma patients, that's actually great, because if they miss even one dose, they can start to become hypercoagulable. And really within 2 to 3 doses, it's probably out of their system in general. And so for people who are up on the units, within 24-ish hours, these are going to be gone. This is also, the other thing to remember about dabigatran is if you can remember to act on thrombin, that's helpful. We can get a thrombin time at regions. The lab tells me the turnaround time is about 15 minutes. And this can really help you because in the undifferentiated setting, if your thrombin time is normal, you're probably not on dabigatran. Remember the kidneys also, and there are two things about the kidneys to remember with dabigatran. First of all, it's not highly protein bound, so it's potentially dialyzable. And in a sick trauma patient, that's one of the recommendations is to consider hemodialysis. Secondly, it's renally cleared, and so you don't want to use these in patients with renal insufficiency if you're prescribing them. And if you're taking care of somebody who's on dabigatran and comes in and they have renal failure, it's going to be around for a really long time. So just keep that in the back of your mind. As far as the Zabans go, they also have a short half-life, so some of those similar pros and cons that we talked about before, but some of them even have a shorter half-life, which may be better for us as we take care of these patients. The other thing to remember is that it doesn't act on thrombin, and so the thrombin time is normal. So again, it may help you differentiate these. Your other labs, your PT, your INR, and other anticoagulant markers are likely going to be abnormal, but they're not going to be, it's not a nice linear fashion like we see with warfarin. They have less kidney involvement, so they're less of a problem in patients with renal insufficiency, but they're also unlikely to be dialyzable, and it's not recommended to dialyze patients on Zabans. It's probably not going to work in the sick patient who needs reversal of their anticoagulation. So the big question, I think, is what we do when patients get injured, because people have accidents. They fall off their bikes, they come in as trauma patients, and this might be me, shortly before I went to the freighter ER a couple weeks ago. But anyway, people come in on these anticoagulations, and we're going to be asked to take care of them. So what do we do? And we don't know, actually. That's a really, really good question. We really don't have any data right now on what the best way to treat people who are sick and bleeding and are taking these agents are. There's virtually no data in humans. There's a couple of animal models and data in healthy humans. There's some good recommendations, and at Regions we have some protocols which you can look up. And I've included some of the recommendations in the notes from today too, so you'll have that with you. But basically we do what we're good at. We work on resuscitating the patient. We treat people like we usually do. And then if they're really, really sick, we try stuff. You can consider charcoal in these patients. They're supposed to take them twice a day, so there's a decent chance that they've taken it recently. And so you can consider charcoal in these, consider activated charcoal in these patients. For dabigatran, if you can, dialysis is an option. And if that doesn't work, considering some of the activated PCC complexes like FEIBA, and there's some case reports of using factor 7 in patients on dabigatran that might be helpful. For the Zabans, similarly, charcoal might be an option. Dialysis is not recommended in those patients. You can also consider PCC, but the end game is that we really don't know what the best option for these patients is, but we're going to see them and we're going to need to take care of them, so we need to come up with a plan at our institutions and where we work as to how we're going to care for these trauma patients. So in the end, you have to know about these. We're going to see them. We're going to be asked to prescribe them, and we're going to take care of patients that are on these agents, and we need to have a plan about it. So hopefully, as you learn a little bit more, you'll be less intimidated by these. You'll be able to be a little bit more prepared to take care of these patients when they present through your ER and your trauma units. Thanks.